Hi, I'm Pietro Mascagni, and today I have the pleasure to present a research performed at IRCAD-IHU, Strasbourg, France, aiming to assess the feasibility and safety of three-dimensional flexible endoscopy in a clinical setting. I have no conflict of interest to disclose. The stereoscopic vision typical of human sight allows us to gain a three-dimensional understanding of patients' anatomy. However, with the introduction of minimally invasive surgery, the sense of depth was initially lost as surgeons were operating looking at a flat screen. In order to overcome this limitation, binocular scopes analyzing the disparities between two slightly different images were introduced more than 20 years ago. In most modern 3D systems, surgeons look at the 3D display through lightweight polarized glasses. A recent EAES consensus on the use of 3D vision in laparoscopy reviewed and pulled data from more than 130 studies and concluded that 3D vision reduces operative times and complication, especially for junior trainees. These at the cost of significant 3D-induced symptoms, especially when the 3D setup is not optimal. In flexible endoscopy, few recent studies assess the value of 3D endoscopy using a recent 3D-capable prototype provided by Olympus. These preliminary studies suggest that 3D vision in flexible endoscopy may improve diagnostic accuracy and speed up complex procedures such as endoscopic submucosal dissection. However, also here they found significant 3D-induced symptoms. Despite its potential, 3D endoscopy is today limited to research, as currently no commercially available scopes are 3D capable. This limitation may be overcome thanks to novel computer vision techniques. Indeed, solutions like the monostereo box visible here at the center of the slide can be connected to a standard 2D endoscopy column to convert the endoscopic image in 3D in real time. In this type of computer-generated 3D, the depth of the image is computed using signals from the original two-dimensional image, such as shadows, textures, and luminosity. To preclinically assess this device, our group compared the performance of endoscopists performing simulated tasks guided by 2D vision or computer-generated 3D images, and found that stereoscopic vision led to significantly better performance, especially among novices, at the cost of very minimal 3D-induced symptoms. Due to these promising results, the aim of the present work was to assess the feasibility and safety of computer-generated 3D endoscopy in a clinical setting. Patients scheduled for an endoscopic sleeve gastroplasty or an ERCP at Nouvelle Hôpital Civil, again in Strasbourg, France, were asked to consent to 3D endoscopy. Stereoscopic vision was provided connecting a standard two-dimensional scope to monostereo and this to a 3D-ready display. Technical problem switches to the two-dimensional vision and adverse events were annotated by a research assistant during every procedure. Furthermore, operator appreciation and 3D-induced symptoms were assessed at the end of each procedure through 5-point Likert-like scales and interviews. And here are the results. Professor Silvana Perretta performed 10 endoscopic sleeve gastroplasty cases guided by computer-generated 3D images. She experienced no technical problems nor adverse events and never switched to two-dimensional vision. Her appreciation of the system was high and 3D-induced symptoms were really minor. When interviewed, she suggested that stereoscopic vision helped better understand endoscopic stitching pattern and the consequent gastric volume reduction. Dr. Ivo Boskowski performed 5 three-dimensional ERCP cases and again didn't have any problem nor adverse event with the monostereo system. He similarly appreciated the stereoscopic effect, however experienced slightly more 3D-induced symptoms, especially abnormal visual field symptoms. Overall, Dr. Boskowski felt that computer-generated 3D vision helped evaluating the shape of the papilla and consequently find an optimal position of the scope to maximize the chances of successful cannulation. In conclusion, this study found that the clinical translation of computer-generated 3D endoscopy is feasible, reliable, and safe. 15 procedures were performed without any problem, and operators reported only negligible 3D-induced symptoms. The depth perception was highly appreciated by both operators, who suggested potential value of this technology. Overall, these findings call for a 2D versus computer-generated 3D prospective comparative study in the clinical setting. Thank you very much for listening, and please don't hesitate to contact me for questions regarding this work. Please enjoy the rest of the virtual meeting. Ciao.